All right. Welcome, everybody. So glad you could all join us for what we hope will be a fabulous session of the Exercises Medicine Research Learning Collaborative. Today, our panel session is focusing on engaging healthcare providers in clinical research. So as always with the EIM RLC events, I like to start off and just ground us all together on what we are trying to accomplish here. So the first thing I think is important to cover is understanding what Exercises Medicine, the initiative is itself. And just really briefly, you can see our vision statement, and it's really about making physical activity a part of clinical care, connecting people to evidence-based programs, all people, all individuals, to evidence-based physical activity resources. So within that, we're really taking a systems approach, not trying to do it provider by provider, but how do we engage clinics and health systems and insurance companies in doing this? So we're looking to affect structural and policy changes, integrating into electronic medical records, and really building that bridge of trust to community resources. But what's needed with that is a really strong evidence base at the core of things. And that's part of what we're trying to do here with the Research Learning Collaborative. So one step further with Exercises Medicine, our key core fundamentals is that routine physical activity screening, the physical activity vital sign integrated into that EMR, then some combination of brief advice and counseling, or even a physical activity prescription. And then that final step, we're referring patients to physical activity resources, whether they're digital, community-based, or even within that health system itself. And this really models after a famous model called the SBIRT, which is often used in drug and alcohol treatment scenarios. So our Research Learning Collaborative really was an idea we started about 1.5 years ago to bring together peers like all of you on this call to share and apply research practices with people from academia and people on the front line. And I think today is a perfect example, getting some people who are actually doing this work, collaborating with providers and showing us the way of how this is done. Really focusing on examining the dissemination, adoption, adaptation of best practices. So we're not here to show physical activity is good or all the multiple benefits of physical activity, but how to really engage healthcare and healthcare patients in these different physical activity interventions. So you can search us, EIM RLC, it'll take you right to our page. If you're not already a member, do sign up. We try and do these events every month or 2 months and just bring this great information to you. So today we have 4 panelists. Really, I was commenting before we started, we have just such a really cool, diverse group of speakers. We're going to start today with Dr. Marcia, who's from Texas A&M. Then we'll transition to Dr. Kelly Hirko from Michigan State, Garett Griffith, and Dr. Mark is going to finish us off today at the end with his discussion about his work. What we're going to do today is each panelist will talk for really briefly. I've asked them to keep it just to 5 or 6 minutes. That'll take us to the halfway point because I really want to open up the second 30 minutes on discussion and questions, what you want to hear, what advice you want to get instead of us speaking the whole time. So as we go along, please feel free to post your comments in the chat room. I'll moderate it afterwards. And we're really looking to have a free-flowing, open discussion for the last 30 minutes. So don't be shy. Please do speak up. So with that, I will stop and I'll turn it over to Marcia. Please feel free to share your screen and we'd love to hear about your work.
Okay, excellent. So share, and then I'm going to put it on slide. And then I'm going to ask everybody, which screen are you seeing? Are you seeing one with a full slide or one with a partial slide?
We got your full slide, Marcia.
Okay, perfect. So I'm going to give you my reflections. I've been at this for about 40 years. I've had successes and I've had failures. So I think we'll all share the successes and the lessons learned. I'm with a Center for Population Health and Aging, And we have a 4C approach, and that is collaboration. We're on a campus, we're in an academic setting. Because we're in public health, we work really closely with the community. But if you want to achieve healthy aging, you've got to work with every sector. So we also work with clinical sectors and corporate sectors, and the arrow should be going every which way and up and down, because it really needs to be a collaboration, intersection of all of these different sectors. So what kind of work have I done? I've done a lot of work on enhancing lifestyle behaviors, primarily physical activity, work on chronic disease self-management, fall prevention. All of these have physical activity as a core element. But then reducing caregiver burdens, a little bit about opioid education, naloxone training, and now everyone seems to be interested in COVID-19. So I think the first thing is, when you're thinking about interactions with healthcare settings, you really have to ask yourself, is the clinical setting integral to what you're doing, or is it more peripheral to project activities? So do you want to interact with the clinical setting just to get recruitment for patients, perhaps if you're doing research? Or do you see the clinical setting as actually engaging in your research, your projects? Do you want them to be implementing the intervention? And what Mark said is, exercise in medicine really wants clinical settings to be implementing exercise and exercise prescription and counseling. But also, are you looking at a clinical setting to help sustain your activity, or you want to go to one clinical setting and have them be peer-to-peer and disseminate what you're doing to other settings? And so I think how you approach a clinical setting or an individual healthcare provider really deals with what your purpose is. So let me just talk a moment about successes and challenges. And most of the work has been around self-management projects. And this picture shows a set of healthcare professionals. But I think we could also put exercise professionals here, because they work really hard and sometimes they get just as tired and as discouraged. But if you're talking about clinicians will tell you, when you go and do the right thing and say, let's talk about physical activity, or let's talk about self-care behaviors, they'll tell you they don't have the time to spend with the detailed self-management. So they say, yeah, we're so glad to partner with somebody like you who will do what we don't have time to do. And then you think, man, this is terrific, great partnership, but no referrals come. So you can't exactly figure out, they say they don't have time, they say they want to partner with you, but no referrals come. So the first thing is really to make referrals as easy as possible and fit within whatever that clinical setting is with how they do referrals. And then another thing is to build in feedback loops. So sometimes clinicians are reluctant to refer their patients out because they want to know what's happening to their patient. So again, remember how important feedback loops are. And so the last slide is really 40 years of lessons do and don't. The first thing is, whether it's research or you want to implement a program, you have to involve the healthcare entity up front in the planning. And that often means finding a local champion. And it's not just somebody in the healthcare setting, but it's somebody in your setting, in your campus setting, who knows how to talk to clinicians, healthcare systems. And the first thing is really to identify common goals. What are our common goals? But then also language, because the term research means something different to a researcher, to a clinician. Even physical activity and exercise means something different. So be sure you're talking the same language. And then carefully specify the roles and expectations on both sides. And we often do memorandums of understanding. As I said, provide feedback along the whole way. And even if you have resources to pay the clinician, to give them incentive, realize, if they're part of your research grant, that usually what they're doing is on top of their existing duties. So they're not getting released from clinical time and clinical expectations. But then I would say, on the positive side, take advantage of new trends in healthcare. Everyone here in Texas and all over the country is talking about interprofessional education, how healthcare can work together as a team. So what you want as an exercise professional is to be perceived as part of that team. And so what are the don'ts, the sort of opposites? Don't expect your passion to be the healthcare system's passion or an individual healthcare provider. And what we've learned, if a setting is reluctant upfront, don't think its success is talking them into participating, because they're probably not going to follow through. And then don't expect the healthcare system will change their electronic health records or their clinical flow for you. That's just probably not going to happen unless you're on the inside. And really the most important thing is don't expect a healthcare entity or an individual clinician to take on any extra burdens. This is particularly during a crisis period such as the pandemic. So that's my short introduction. Thank you so much.
All right, thank you so much, Marcia. I believe Kelly, you're up next.
Okay.
And again, as she readies her slides here, the whole purpose is just to give you an introduction with our different speakers and their areas of expertise, so that we can dive into discussion a little bit deeper down the road for the second half of the session.
Okay, I'm not seeing my slides. I'm going to share my desktop and see if I can get to my slides, if that works. Sorry about that. There we go. Can everyone see that? Okay, perfect. So thank you for the opportunity to speak today. I want to start with a caveat that I am not an expert in this. I'm kind of learning on the fly as a community-based researcher based in a clinical setting for the past 5 years. So today I'm just going to briefly talk about some of my lessons learned in this brief time of collaborating with healthcare providers to address rural cancer disparities. So I am an assistant professor in the Department of Epidemiology and Biostatistics at Michigan State University. Michigan State University's main campus is in East Lansing, which is shown in one of these dots here. But Michigan State University's College of Human Medicine is a community-based medical school, and they train their medical students and residents at community campuses throughout the entire state of Michigan. And I am based at the community campus site in Traverse City, Michigan, in northwest lower peninsula of Michigan. And my office is based at Munson Medical Center, which is part of the Munson healthcare system. This is a large rural clinical healthcare system. It serves over 500,000 residents across 30 counties. It's a total of 11,000 square miles. So they often cite that it's the size of Delaware and Vermont combined, this service area for this hospital site. And Munson Medical Center, where my office is the flagship hospital for this healthcare system, but the healthcare system includes 9 community hospitals throughout the region. So my role as a community-based researcher, beginning in 2016, I am expected to, like any assistant professor in my department, to conduct my own scholarly research. My research largely has focused on energy balance factors such as physical activity and diet in cancer prevention and cancer survivorship. And I'm particularly interested in using implementation science approaches to bring evidence-based lifestyle interventions into settings that can address rural cancer disparities. So as part of my role, I'm also expected to work collaboratively with community partners and with clinical partners to address their needs. So it's a really unique position because I have my own research interests that I am pursuing, but I also, as part of my role, am really meant to facilitate research and facilitate quality improvement projects with clinical partners and with community partners in a rural region. And so I'm just going to provide a brief example of one project that I've been working on to promote physical activity for cancer survivors. So I have a picture here on the slide that shows the Cowell Family Cancer Center. This is the main place where cancer patients are treated for this entire Munson healthcare system. And it's based at the flagship hospital, Munson Medical Center in Traverse City. But we have patients who come to receive cancer care from hundreds of miles away every day to this rural site. And so when this center was opened, it was only opened about a year or two before I came in 2016. And one of the donors of the site was really engaged in trying to promote health and well-being. And so an entire floor of this center was devoted to health and wellness offerings for cancer patients. And one of those programs was a physical activity program for cancer survivors. They could participate at any point throughout their care. And we had oncology certified fitness trainers available to facilitate group classes with these cancer survivors. But really, upon working in the system, it was clear that there was a very low uptake of use of these programs. And so through some of my clinical partnerships that I had formed, we talked about how we could overcome this from a research perspective, using some of the skills that I could do as an epidemiologist. And we thought that maybe by conducting a research study to really be able to show the benefits of this program. Yes, we all know that physical activity is good for cancer survivors, but oncology providers are busy and they might not, have the time in their conversations to initiate these conversations with patients to suggest that they are referred to these on-site programs. And so we wanted to document some of the quality of life improvements in patients who went through the programs. And so we did this study where we were using validated metrics to look at quality of life and sleep quality for participants who went through the physical activity program. And over a 2-year period, we had only about 25 people go through and participate in at least 5 classes, which was our goal, to be able to have a pre-post assessment. And so we really kind of shifted our focus and published this as more of a commentary here to talk about the challenges and opportunities for promoting physical activity among cancer survivors. And through this study, we really learned important barriers that were limiting participation. We learned that participants weren't largely being referred from oncology providers. And we also learned that a lot of participants said, I've been coming to this cancer center for the last 5 weeks to have radiation. The last thing I want to do is come back, drive 100 miles to do a physical activity program. And so this research study really is setting us up now to develop tailored approaches that we can use to promote acceptable physical activity programs. And we've learned that we need to make it easier for oncology providers. So we're working with IT to integrate the provider referrals into the system, and also recognizing that just one on-site physical activity program might not be acceptable or feasible for many of our rural survivors. And so we're thinking about a menu choice of other options and offering community-based participation for cancer patients who are interested in participating in physical activity programs. So here are my lessons learned from my collaborations with clinical partners over the past 5 years. I don't have the breadth of knowledge or experience that our previous speaker had, but I'm happy to see that some of the lessons learned kind of overlap with what Marcia was describing as well. The physical activity program was one of the projects I've done, but I have been involved in a lot of different projects. And so these are some of the lessons that I've learned through my experience. I really, truly think that the success of research depends on partners' involvement throughout the research process. So it doesn't work to come in when you have your grant funded and say, this is what I want to do, this is how I have to do it, can we make it work? We really have to involve the partners, the clinical partners, in the conceptualization. We can tailor our approaches to kind of meet their own needs and make the project feasible and sustainable. I think I've learned that I need to be flexible. This goes along with this prior point. We can't necessarily go in with a rigid plan and think it's going to work in each individual setting. So be flexible and align the research with clinical interest in order to gain acceptance and commitment from our partners. So, sometimes I try to think about what I'm trying to do, my common goal, how that works with the goal of the clinical setting. And maybe there's a quality metric that they need to meet that we can say, okay, this research will help us identify strategies that can help you actually meet this quality metric. And so we align our interests to meet the goal. I think I've really learned that this seems really obvious, but that it takes time, that you have to listen to your clinical partners. You have to show up and support other clinical efforts. It's not all about what I want to do and how I want to do it. It's about being a partner and helping in other clinical efforts that are important to the institution. And then it builds that relationship and trust. I also think, as was mentioned before, that it's been very helpful to have trusted stakeholders and champions that you've identified in your work that can help facilitate making connections for other research projects. And, you know, I often try to think about it as building a relationship like you would in any other setting, and reach out to these individuals without always asking for something. So reach out to, you know, see how things are going, ask how I can help, not only asking when I need a letter of support for a grant, or not only reaching out when I have a question because recruitment's slow, but reaching out and keeping that an authentic relationship with the clinical partners. And finally, I think recognizing that the knowledge that a clinical setting and our clinical partners brings is really valuable to ensure that we're implementing and studying appropriate and acceptable solutions so we can learn from each other. So recognizing that it is a true partnership and we each bring unique skill sets to impact, to have a better impact long-term. So that's all I have. I have my contact information here if anybody has any questions afterwards, but I look forward to the discussion.
Perfect, Kelly. Thank you so much. Garett, you're up next.
Excellent. Is everybody able to see that slide? Yep, good. Just wanted to start off by saying thanks so much for everyone tuning in today. Thanks, Mark, for putting this together. I have a bit of a different perspective as the previous panelist, not an assistant professor yet. Hopefully this upcoming May will graduate with my PhD and transition into that role. But my experience has really been as a laboratory manager, as a clinical research manager. So I've really built my career around this concept of linking in clinicians with professors, with PhD students, with research staff, and understanding and conceptualizing all these interrelationships between all these different stakeholders in the research process. So a panel like this really was pretty exciting to be a part of, and it's exciting that the the Exercise is Medicine RLC is kind of diving into this further. But I'm going to share some lessons learned. A lot of what I'm going to share echoes and amplifies what was shared previously. I think there's a lot of these shared experiences, so it's great to hear sort of different vignettes of different settings. But I'll talk about my experiences in Chicagoland, both at University of Illinois at Chicago, as well as at Northwestern University. So at UIC, helped manage the Integrative Physiology Laboratory, and there we had a handful of different clinical projects going on with multiple sclerosis, diabetes. This is just a small snapshot, but what I wanted to highlight in this is that as exercise professionals, as sort of public health minded folks, as nutritionists, as sort of an ACSM cohort of researchers, we definitely have skills to offer clinicians. I think it's important to know that we are professionals in this realm, and if clinicians do have any kind of questions about how maximal exercise testing might work, how resistance training might work, how you develop an exercise prescription, these are all things that at UIC I was overseeing and being involved with, kind of being advocates for our clinicians, helping them build that bridge and understanding how this might fit into clinical care. There was, slides shared earlier about making sure that clinicians don't lose touch of their patients within a clinical trial. That's an excellent point as well. But just wanted to show a handful of the skills that we as a profession, as a wide range of researchers do have, and that's definitely appealing for researchers or for clinicians. I've been able to reach out across the aisle, introduce myself, introduce the skills that we have available, the resources and equipment that we have available in different exercise contexts. And those have always been very fruitful conversations. So the first piece of advice is just go ahead and reach out, identify individuals in your content area of interest, clinicians, and they're more than likely, from my perspective, willing to have that conversation, kind of brainstorm a little bit. They're very, very active as a clinical cohort. So at Northwestern University, patient populations have shifted a bit more towards Parkinson's disease, stroke survivors, cystic fibrosis, fatty liver disease, these kind of things. But once again, been able to be very successful in helping clinicians navigate a complex research infrastructure. A lot of times they, from my experience, can be a bit intimidated, don't necessarily know, depending on their level of training, of how to submit an IRB, how to write an informed consent. Not only is that sort of potentially a confusing, daunting process, but just like we said earlier, the clinical demands of those kind of jobs, it can make it challenging to fit that time in as well. So helping them navigate what the expectations are, how to do high quality clinical research is going to be important to be transparent early on. But I had some examples of outreach efforts that I've done pretty successfully to kind of spread the word of resources. From my experiences, not everybody, not all clinicians in an academic medical center might even know that our resources are on campus. And so just making that aware is always a big first step. I've been able to sort of do a lot of Google work, do a lot of, prowling the different academic medical center pages to understand what clinicians are working in content areas, which ones are a bit, academically and sort of research involved. So you kind of target those folks, or kind of send more broad emails as well. Building the bridge with the researchers that you're working with in the academic center, understanding what their skill set is, what their content area is, to help kind of identify those targeted folks is helpful as well. The open houses and tours have been great for us, inviting clinicians over during lunch breaks, after hours, kind of navigating around their clinical schedule to help them understand what research might look like in that space, what skills can you offer to help with that collaborative effort. Listserv-wide emails have been helpful as well, just to kind of cast a broad net, start conversations up wherever they might happen. And lastly, having a strong presence online. I've been contacted several times by clinicians who just kind of stumbled upon when Googling Northwestern's resources that I'm an exercise guy, and they wanted to talk further. So it's kind of some more organic conversations that have started up as well. So don't be afraid to really put some effort in up front. It definitely takes time on the front end to build those relationships. Like we talked about earlier, don't just sort of look for a one-sided benefit. It's got to be collaborative. But those are some good tips, I think. And then in terms of, I've had a lot of experiences with clinicians where they might be interested sort of in theory, conceptually about doing collaborative research, but actually bringing that to the starting line, actually getting a study approved can be challenging. So kind of working through what resources you have, what exactly is required to do IRB submission, and then further, once something is approved, the monitoring requirements, the adverse event interpretation requirements, the delegation of authority log requirements in a clinical setting, are all certainly things that, from my experience, unless a clinician has a very strong research background in their fellowship or residency, maybe expose them to that. Some folks are interested in the concept, like I said, the mechanics of research, thinking about it from a standardization process, from a data management process, from a quality of standardization of intervention type process. All those things definitely take a little bit of upfront investment of time, energy on your part as a researcher to make sure that that's being done well. But most of all, being proactive, making sure that you're not afraid to kind of reach across the aisle in these different ways will certainly start for meaningful conversation. So that's some lessons I've learned as sort of that research manager, clinical research manager type perspective. Been successful for me, but looking forward to the conversation as this grows throughout today's session. Thank you.
Awesome, Garrett. Thank you so much. Last but not least, Mark, turn it over to you.
Perfect. If you can just let me know if my slides have come through, that would be great. Yeah, great. Thank you, everybody. Good morning to colleagues in America and good evening to colleagues in Korea as well. It's a phenomenal effort. My name is Dr. Mark Faghy, and I'm an associate professor in respiratory physiology at the University of Derby in the UK. For those that haven't been to the UK, I don't know where Derby is. It's an hour north of Birmingham, and if you don't know where that is, that's 2 hours north of London. So that's kind of roughly where we are. I'm going to come at this again from a slightly different perspective. It's really interesting to hear colleagues' thoughts and experiences of clinical research. And if you can see me on the chat, I've just been nodding whilst everyone's talking. As I was preparing my slides, I was like, oh, is that just me that's experienced it that way? But I'm glad to hear that that's certainly not the case. And we've got some shared commonality and experience of challenges, which I think is fair to say. So I'm going to briefly talk about my research. Essentially, I'm a sports scientist and exercise physiologist by training. That's where all my background is. And prior to researching clinically, I've managed to travel the world supporting elite athletes, but I definitely get more of a kick out of supporting patients than I do sitting in airports and hotels around the world. And I use my physiology training, my background in exercise science, to support patients with acute and chronic respiratory conditions, which during a global respiratory pandemic has kept me very busy. But what I'm going to do is kind of show my transition through clinical research through the course of this slide to give a bit of a context to the work that we're doing and the collaborative thinking and work that's happening, because we're a massive advocate as part of our research group for whole systems thinking and whole system approaches, which Mark mentioned at the start. So I'm going to try and connect a few of those dots together as well through this little bit of a talk. So what I've decided to do is to break my research journey into 3 stages. Pre-COVID, which feels like a lifetime ago for us in the UK, and I'm sure that's a sentiment shared by colleagues across the globe. my current focus, because it's changed phenomenally very quickly, and then what the hopes are for the future. Pre-COVID, I was working predominantly with 2 hospital trusts in the UK, trying to understand the determinants of recovery for pneumonia patients. So radiographically, after a course of antibiotics, and pneumonia is gone within about 10 days, but they have persisting symptom profiles that last weeks and months post a pneumonia episode. And what we were trying to do was to work out how we could best support those patients by overlaying interventions that are shrouded around the exercise is medicine theory, and trying to improve recovery outcomes for those patients. Alongside that, and I'm not going to dwell too much upon this, we've also got some funded work in COPD patients, again, trying to increase functional status by increasing physical activity through targeted approaches, and we've got some industry partners and industry funding to support that work. And then in January 2020, all of that work, bar the COPD work, was paused because COVID came to the UK and was, repurposed all of our focus. And I'm really proud to actually lead an international collaborative group on COVID recovery research. So we took the learning that we'd obtained from our pneumonia patients and we repurposed that into COVID research, primarily because of the similarities in the symptomology that is persistent in a post-COVID period. We were one of the first groups in the UK to actually go to the government and talk to them about long COVID, and that being COVID long haulers, as it might be in the States. So really kind of, highlighted that, and we're, leading an international group across the United States, the UK, and also in India, trying to understand the determinants of recovery so that we can support those with COVID specific interventions. And I'm delighted to be working with, an international group on that. The COPD work has continued despite pauses on clinical research in the UK, and we're at a point of, we're running a series of clinical trials, and the aim and aspiration for our work there is to look at non-medicinal interventions to support improved quality of life and functional status. I haven't got a clue what the future holds. I think if you'd have asked me 2 years ago, I wouldn't have even talked about the whole COVID thing. So I've gone past thinking too far into the future, very much living by the day and by the week at the moment. But, I think there's a lot of work to do in around COVID recovery and long COVID work. And, that's definitely the priority for the group at the moment. I would love to return to the pneumonia work, and possibly will do, but I'm not going to even hazard a guess where I'll be in 2 years. So there's that. I'm just going to briefly go through the lessons learned, because I know this has been covered by colleagues previously. I think it's fair to say that clinical practice and healthcare providers have a very different view of the world. From an exercise science performance background, we're looking to make people fitter, faster, stronger. That's not necessarily the view that they're going to be coming at it from. So you have to be mindful of what their drivers are and what their motivators are for engaging with research. And that definitely links into the next point, because they're definitely talking a language I don't and still don't fully understand. They have a very different perception of what patient benefit is and how we can improve those patients. So you have to be mindful and acknowledging of those conversations when you're engaging them. They absolutely do, and I would encourage anybody to engage in these conversations, because they love collaboration and they have lots of fantastic ideas, and colleagues have already mentioned the constraints on time. I almost viewed that as my role, as that's their challenge. Now where's my solution, and kind of bringing that to the table to support those. But you have to be able to articulate the patient benefit, or what the relevance to their work is, because again, like I say, they have a different view of the world, and they go to work every day. They've done several years of medical training to improve patient outcomes, to make patients better. So you've got to be able to articulate what those benefits are and how it's going to help them in their role. And that's something I don't mind confessing, learned probably the hard way. I think initially I was a little bit naive to that, but now definitely that's at the forefront of my thinking, and it really does support that collaboration between partners. You definitely have to be patient. These are very busy individuals. They're shrouded in other roles and responsibilities, and the due process that takes place. So you have to be prepared for things to take a little bit longer than you might like, but factor that into your planning and communication, and you'll definitely have the solution. And again, just as colleagues have said, we need to consider the implications for involving these people in your work and what it means. They still have their ward rounds to do and their paperwork to do, etc., alongside all of this. So they will be doing it because they want to, not necessarily because they need to. So we have to kind of be mindful of that. And I'm very much taking on the point that Garett made about being proactive and having that opportunity to offer something. And I think Kelly mentioned that too. So finally, yes, working with clinical partners is challenging. There's lots of due process, administrative tasks that you might not necessarily find in a non-clinical environment. There are challenges and obstacles that we need to overcome. Like I say, with the COPD work, one of those we had was actually overcoming a global pandemic in respiratory conditions, trying to conduct respiratory research. It wasn't viewed as a priority at that point, so it was paused temporarily, but we're back on track now and researching that. There are lots of process. I think a few people have talked about IRBs. It's the same process in the United Kingdom. We have a separate entity that looks after the research governance, and it's a minefield, one that once you've navigated, it's easier to navigate a second time. The first time is a bit like getting lost in the woods, but eventually you find your way out. But it's 100% rewarding, and I'm really pleased and privileged to share some very strong collaborative relationships with clinical partners and acknowledging the impact of the work that we're doing. Thank you very much.
All right, thank you very much for that brief introduction, everybody. That leaves us with a good 25 minutes. I see a couple of questions. Christina and Charles, we'll get to your questions. I want to take the prerogative to ask the first question. And maybe panelists, we try and limit our responses to about a minute or less, just so we can get through a number of questions. So my first question is, how did you go about connecting with healthcare providers in the first place? Like, how did this happen? What are some of the key strategies or considerations that helped you establish these relationships? Because, for someone who isn't in this field, it might be daunting. It's like, how do I approach people and get this thing started in the first place? So, feel free to jump in and share your experiences really briefly with that.
This is Marcia. What I would say, being in public health, we already have community collaborations. We already have coalitions interested in health. So we in public health are part of those coalitions. That might not be for everyone, but when you go there, you find clinicians. They say, come to my medical director's meeting at 6 in the morning. So again, find an avenue where you have commonalities and then follow the strategy that will work best. If it means for a night owl getting up at 6 a.m., you do that.
Yes, I've definitely been at some 6 and 7 a.m. meetings. Yeah, everyone's shaking their head. Yes.
Yeah, just to add to what Marcia said, if I may, I think one of the other, you've definitely got to show willing and be there around the commitments, but also as well, I think I briefly touched upon it, but again, it's kind of highlighting the benefits to them and the patients that are there. So we all know the impact of what our work and regular physical activity could do. The clinicians know that too, but if you can join the dots together, it makes conversations much easier. And it is daunting. And you do, I think, I did include, but I took it out, was one of the things you have to do is take yourself out of your comfort zone a little bit. We all have areas where we can talk and we're very knowledgeable, but if you can put yourself at a table with somebody who is extremely knowledgeable in medicine and highly trained in that area and articulate a patient benefit, that is the battle. Once you've got that bit, that is the start of your relationship in terms of, for collaborations and research.
Yeah, I will just add to that, it does take time because you have to really be authentic in building a relationship. And then through that, for me, it really helped because I identified the champions that I could use then who were really supportive and who would reach out and get other providers involved because of their own role. So, take the time to build relationships and identify those champions who can facilitate your work in practice.
Yeah, I would absolutely echo everything that's been said already. And I would additionally recommend getting on listservs, going to grand rounds. There are sort of these targeted presentations, whether it's a seminar series or lunch and learns. I've been lucky enough to be at UIC and Northwestern, where that's a big priority, and sort of the university is tucked within an academic medical center. But making sure that as research is being presented in a topic area of your interest, whether that's pulmonology, public health, cardiology, whatever that might be, don't be afraid to ask questions, reach out afterwards with the contact information that's provided, make sure that it's known this is a priority for you. And like has been said before, that you're someone that's willing to help out with the process, and because it is a big lift to get a project off the ground. And so that's going to largely fall on the researcher's hands, not entirely, but you have to make it known that that's going to be feasible.
So we have go to them on their time and their time frame, find champions that help spread your word, use existing connections and collaborations, and connecting the dots and really showing the value of what you're proposing. So those are some of the key takeaways I had in establishing those relationships. Awesome. So I'm going to circle to Christina's question here, and they've been developing this really unique program, and they want to get it into the EMR. What are your experiences? And Marcia, you said in yours that don't expect them to change the EMR, but how has anyone had successes in making those changes, and how do you go about doing it in integrating stuff into the EMR at your systems?
I think it would work better if you were inside the system. And I think when you're on the outside, you think just add 2 additional questions. You don't realize as an outsider, that's $1 million ask for people to change their electronic health records. So understand the clinical flow and the infrastructure on the inside, and then you'll know what is a reasonable ask or not.
And I think being able to make the case as you're sort of pursuing these ideas, at Northwestern, we work with the chief informatics officer to kind of talk through those questions. What does it actually take? And those are conversations that were way above my pay grade. It was mind blowing to see what would have to happen to have those changes. But being able to say this would be a system-wide benefit. It wouldn't just be for this project. This is going to benefit collaborations going forward. It's going to add value across all departments. I think then as the administration and as the leadership team is weighing, is it worth this $1 million? That sort of reward gets greater as you make the case that several different departments will benefit. You kind of build a coalition internally, I think helps those conversations.
Yeah, agreed. Just to add to what Gareth said there as well. Sorry, apologies. What's also as well, we're talking about establishing relationship with clinicians and wanting to do really impactful research. The process side of it, which I definitely alluded to in my talk, is almost kind of a separate conversation, and there will be all systems and organizations within hospital trusts or clinical spaces that can support the development of those conversations. So you wouldn't want to overburden a clinician with questions that might be process driven, but find the contacts or the people within the system that aren't the kind of the clinical leads or the team leads that can help and facilitate how we can alter that process to as a result or the research or in order to do the research effectively. So yeah, there's almost like a big team behind the clinical representation where you could kind of get that support from, and they are also really willing to facilitate research.
Kelly, yeah.
Have much to add. I would just say that I've been working with the digital health team and really understanding, what those barriers are, because as was alluded to, sometimes it seems like a really simple ask and it's not easy to make those changes. So working from the conceptualization phase with the developers of the programs has been helpful to realize what could be an appropriate way to do it.
Thank you all very much. Lori, what do you want to unmute and just really quickly, like 30 seconds, give a discussion what the HL7 is? Lori is from the American Heart Association.
Sure, Mark, can you hear me?
Yes.
Okay, really, I didn't mean to. So we were at the HL7 work group meetings last week. We have funding now to engage in the HL7 process and are working with Jeopardy Consulting and our measure development team at the American Heart Association to develop these standardized measures, engage with the HL7 process. It's a 5-year plan to really make this happen. 3 years, to really do the significant work. So it's a big lift, but we're excited to have it underway now and to be headed down this road, and look forward to staying in touch with you about how it's going. It looks like we may be developing our own implementation guide to take through the HL7 balloting process.
Awesome. Thank you, Laurie. Maybe in the future we can even get you on and you can do a whole presentation on this effort. So I'd like to
do that. Thank
Awesome, thank you. And some really exciting work that the American Heart Association is leading, and I do think we need to feature that in the future. So we will follow up with you, Laurie. Want to circle back to the question, Charles's question. So we talked about the initial establishment of partnerships and how to do it, and the panel all gave some suggestions. But let's talk about that faculty member who might be external to a health system, but interested in doing work and maybe getting their students engaged. Any comments on like what type of initial projects to get your foot in the door, get things started, and how to maybe even get students engaged in this line of research?
I would say the same thing we say about physical activity. Start low, go slow. So don't imagine an NIH $1 million grant, but think of something that a resident, a medical student on rotation can do. Have a small project where it can be seen as implementable, it has immediate benefits, and it can then ripple up. So start low, go slow.
I would echo that. We have medical students who train at our setting and are required to do research projects. And some of the projects that I've gotten them involved with is even conducting focus groups among patients or providers to ask about what are those barriers to making the referral, or what is the barrier to participating in physical activity. And all of that information will then inform a really appropriate intervention down the road. But it's more feasible for those first initial projects and really doesn't demand too much time or resources from busy clinicians.
I think just to add to what Kelly said there, when I was talking about the pneumonia projects that we ran, initially we started with feasibility projects just to kind of, obtain some data that we could work to inform the development of a bigger research program. So bringing in what Marcia was saying and what Kelly was saying about, kind of starting with a small focus and then growing that over time. And it does go back to that, acknowledging time. And I've engaged students from our undergraduate and postgraduate courses in all of our activity around assisting with data collection and getting that exposure to clinical sectors. And that's really important for the students' development, but also the development of the project, and they go hand in hand. So yeah, definitely encourage that. But again, echoing what Kelly and Marcia have both said about, kind of using the platform, the opportunity to grow, and there are pots around for CCORN projects and CCORN funding, which could be used to facilitate, time and, student support. So yeah, that's what I'd add to that.
Yeah, and just an additional strategy that we've used quite a bit when clinicians reach out or vice versa. We try to understand in a given patient population what the clinical schedule is like, what assessments are already being done, that we can kind of piggyback off of, sort of use some of those data from a clinical perspective and sort of marry it with what we're doing in a research setting. So we're drawing meaningful conclusions, maybe answering a nice question, but really not adding too much time to a clinician's plate, not adding too many more visits to a patient's plate, trying to make answer meaningful questions that way, I think is a good way to minimize burden and still bring value.
Fantastic.
Really important point.
This is really great stuff, and I love the chatting from everyone, Sammy and others. Thank you for doing that. I'm trying to follow along. I had a private question here from Anne Marie. It was specific to cancer, but I actually want to expand it to all patients. So panelists, what are the ways you focus on supporting clinician needs and goals while still advocating for the physical activity or the health promoting behaviors that you're interested in? So how do you support what they're trying to achieve in the clinic setting while still getting at the aspects that might not jump off the page that are so important to them?
Yeah, I'll kick that off, Mark, if that's all right, and give a UK context to that. And of all the experience of the clinical personnel and clinicians that I've worked with over time, we've all had the same outcome. It's improving patient outcomes. It is making an improvement in terms of a particular thing, whether it be quality of life, activity of daily life, functional status. The outcome is always the same, and what we're trying to get to. It's proposing different methodologies or approaches to actually achieving that. And there is, through the, exercises medicine, agenda, growing reputation for, advocating physical activity and using that as a preventative and, rehabilitative tool to support that journey. And whilst that, continues to gather momentum, there is an emphasis and kind of growing need, but enthusiasm for that from clinical partners as well. So, I think I mentioned in my talk the use of non-medicinal interventions that, is incorporating physical activity and good healthy lifestyle behaviours. And that's going to grow as the reputation of exercise medicine continues to, reach its potential around the world. And there is that appetite from there. So we're trying to get to the same point, but we might have, traditionally looking at it from a different perspective. But that's where the conversations, and most of mine tend to happen in a coffee shop over a coffee, is about, well, okay, well, you want to get there, I want to get there. This is what you would normally do. Why don't we have a look at this? And that is kind of the spawning of, some of the feasibility projects. That, I think definitely, Kelly mentioned some really great examples in her talk as well.
I think clinicians understand risk factors. So when you're talking about the common goals, Mark, as you just talked about, to bring up the role of physical activity, exercise, in achieving, better functioning, better health, better quality of life, to make explicit what the benefit of activity may be. Everybody has the same goal, but they may think medicine will get me there. And so they need to understand the role of physical activity and exercise as a personal medication and not pharmaceutical.
I think for me, with engaging providers, I often start with, the focus on this is an evidence-based intervention. This is an evidence-based program that has shown all of these benefits in all of these meta-analyses. We don't need to prove that in our setting, but what we need to do is try to implement processes that will translate this finding into this setting. And so kind of getting back to Anne-Marie's question about how do you kind of marry the implementation with the research science question. I propose a lot in my grants to do hybrid effectiveness implementation trials. So you're implementing, but you can also try to have a scientific question of, is the delivery by telehealth as equal in effectiveness as the delivery that we offer in person? And so you can kind of try to do both with a hybrid implementation effectiveness trials.
Yeah, and from my experience, I suppose a lot of clinicians sort of, have worries of, the compliance with an exercise plan, those types of things, sort of the behavior change aspect. And a lot of times with research studies, from my experience, you sort of have a built-in study team member, research staff helping out with, touching in with research participants or sort of supervising in person every so often if it's a training program. So helping them understand this does have almost an additional level of oversight and benefit to the patient to have that more individualized attention throughout the course of a program, I think is a good selling point as well.
All right, fantastic. We have approximately 5 minutes, so we're going to do one final question, and this is mine. So with everything you've said, and people who are brand new to this field or struggling, can you give us your biggest lesson learned, your most important, your pearl of wisdom that you've learned about a mistake you made, or how to avoid it, or how to be successful? So your biggest example, go ahead, please.
I'll go. So I think we have to recognize that these linkages are so important, and that working together will benefit patients, healthcare systems, exercise professionals, researchers. So what I would say is follow the do's and don'ts that we've all talked about, but be aware that there are going to be some bumpy spots, as there are in any relationships. So be ready to be adaptive. Listen to your counterparts, understand their issues, and be ready to jointly solve problems as they will arise.
Yeah, excellent points. I guess I'll jump in with just being aware of the timeline of these kind of things. It took a bit of time for me to realize after a few collaborations with clinicians, there's definitely a downstream benefit, but it's going to take that upfront investment. We talked about showing up at 6 a.m. meetings and going to grand rounds. I've met with clinicians on weekends because they just didn't have the time during the week. And it does take a lot of that sort of outside of our, workday as well. But the benefits are tangible once you start, protocol rolling, you build those collaborations, it grows into the clinician's colleagues and vice versa. It's certainly worth it, but it does take that initial effort, and it's not a small effort.
I would just add to try to keep in mind that you're going to need to adapt and be flexible, but recognize that in adapting and being flexible in your research plan, it'll probably be more likely to lead to a beneficial and sustainable program that will be maintained after your grant money is gone. So recognize that there's mutual benefit in getting that insight from your clinical partners early on and involving them throughout the process.
I wish I'd have gone first answering that question now. Two little things that jump out that haven't been mentioned just yet is Kelly briefly mentioned there about the kind of the next stages. Always keep an eye on what's next in terms of the projects and the development. And these projects we've talked about starting small and then growing them organically in time. So thinking about the scalability and where the impact is. The other piece of information or kind of nugget of information I'd have is bring the stakeholders in early doors, all the people that are important to the implementation and realization of the impact. So we talk about interventions regarding physical activity, get the patients to give their perspective on how feasible and tolerable that might be, using that in the design phases of the interventions, as well as testing that in terms of its efficacy, because they are the people that will want to or will be involved in those moving forward. So patients are a key stakeholder, but also the policymakers as well, because if they can become advocates for your work and for the work that you're trialing, it makes it easier to obtain some of that grant funding to scale that to the next level. So engage all of the important stakeholders, have a think about who you might need to get around the table to support the work, to develop the work in a way that it becomes scalable and sustainable for the future. And that links back to what you said, Mark, at the start about that whole system.
Well, and with that, we're 1 minute to go. I want to thank everyone, both the participants for members and audience for joining us, and the panelists. Thank you so much. That was absolutely brilliant. That was exactly what I was hoping for. Thank you all so much for a wonderful presentation. We will send it out via email and post it in our archives. But again, thank you all so very much.
Thank you.